Hello, everybody, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm your host, Dr. F. Scott Field, and I've got with me a friend, a peer, a confidant, somebody who's got an awesome life journey that I cannot wait to dive into because it is not only remarkable what she's doing, but the why behind what she's doing is really the key takeaway here. But Dr. Jen LaCrosse, Jen, how the heck are you?
I'm great. How are you doing today, Scott?
I'm doing good. I'm doing good. Why don't you tell our audience a little bit about your academic journey and how it's led you to where you're at today? Because this is one of the more interesting journeys for sure.
Well, first, thank you so much for the invitation to be on the podcast. I'm a longtime fan, so it is a true honor to be on here with, like you said, a friend and a colleague. But my name's Jenny LaCrosse. I am currently a postdoctoral research fellow at University of Michigan in both the departments of obstetrics and gynecology and mechanical engineering.
Mm.
So that is not where my journey started. So I think to kind of appreciate where I came from, I'm going to go back to my undergrad. And I think, like a lot of the guests on your show, when I first started my academic journey, I thought I was going to go somewhere very different than where I ultimately ended up. I came into college thinking that I wanted to be pre-med. My dad is an interventional cardiologist. I wanted to follow in his footsteps, but I also love Spanish. So I was planning to major in Spanish, and then I was going to do pre-med at the same time, and then very quickly learned that I could not pass calculus. So I thought, well, I'm not going to be able to take the MCAT. And so this was pretty early on in my freshman year, and I started to meet a lot of people in the School of Kinesiology. At the time, I was like, Kinesa, what? Had no idea what it was. I never heard of it. But the more that I learned about it, the more I thought, I've always been physically active. I grew up a dancer. In high school, I played lacrosse, the irony of which is not lost on me. At the time, my last name was not LaCrosse. And so I thought, I think this is something I want to look into more. I found athletic training, which at the time was a bachelor's, so it was an undergraduate degree. And I decided that I thought that was the right path for me because what really drew me to that program was the fact that you got to have clinical experiences starting your sophomore year of college, which was the first year of the program. And I'm a little bit more of a doer. That's how I learned. So I loved the idea of doing didactic work and skills labs in the morning and then getting to apply those skills immediately the same day in clinical. Went through my collegiate career. Men's ice hockey at Michigan was actually my big sport. I spent a little bit over a year with them. Got to go to the national championship. Unfortunately, that year we lost in double overtime, which was devastating. But I loved ice hockey. That's where I was first exposed to hip and groin injuries, which is a passion of mine. And so I thought, I want to go to PT school because the element of athletic training that I liked the most was the rehabilitation. And so I thought, I want to be a rehab director. I want to work in ice hockey. Went to PT school. My first clinical was at the Institute of Physical Arts in Steamboat Springs, Colorado, which was a phenomenal experience. And even though they didn't have any pelvic health therapists, there's not very many clinics, at least there weren't at the time in Steamboat Springs. And so they had a patient come in that had urinary incontinence and a patient that came in that had painful sex or dyspareunia. And at first, as a first-year PT student, I was thinking, why on earth are these people in a PT clinic? Like, what can I or my CIs do as a physical therapist to help with these conditions? And even more so, in their initial evaluation and even just walking into the clinic, I was so struck by how much these conditions affected their entire lives. And I'm not diminishing the effect that athletic injuries have on athletes, especially when that's how they have scholarships, if that's their professional career. But when you cannot be intimate with your partner and it's affecting your marriage, or you can't do things with your kids or your friends because you're too embarrassed that you're going to leak urine, that to me was just so profound. And then I was really like, why are these women in physical therapy? Like, we need to get them help right now. But lo and behold, at the end of this 8-week clinical, their symptoms weren't completely resolved, but they had improved so much. And that's pretty much what won me over. I was like, oh, I think this pelvic health, women's health thing is for me. Luckily, I went to PT school at Washington University in St. Louis, and Dr. Tracy Spitznagel is there. And she's kind of one of the pioneering educators and researchers in pelvic health. And so within our curriculum, we actually get quite a bit of women's and pelvic health, and I'd say substantially more than almost any program in the country. And so I went back to PT school and I told Tracy that I was so excited about this, but that I still wasn't really sure about the internal work. I was still on the fence about it. Like, I don't know if I can do that. And so she had suggested to me that I shadow with her in the clinic and that I take a level 1 pelvic health course, because as a student, you can do that. So my second year of PT school, I took a level 1 course. And after the first couple hours, they have you do the internal assessment quickly because they know everybody's worried about it. Like, oh, this is just like assessing muscles anywhere else in the body or function anywhere else in the body. It's just one more manual skill that you have to learn to digitally insert a finger. This is totally fine. I'm all about it. And I never really looked back. And so at this point, I was pursuing pelvic health pretty heavily, and I knew I wanted to go into a residency. And the reason why was because I felt pretty confident on some of the basics. I got to do my final clinical rotation at UNC Chapel Hill with a phenomenal CI, Jen Harrington, who was really kind of essential in my development as a pelvic health physical therapist. And so I felt like I had a pretty good foundation, but I thought about some of the more complex patients that I had seen with her, and I didn't feel confident that I would be able to help these patients. And I felt like she was actually the first resident that went through Pitt's residency program, and so that's where I ended up applying and going. But, you know, I really wanted to elevate my clinical practice quickly, and I wanted to be able to serve this patient population. And I knew at the time that I wanted to stay in clinical practice. I was dead set that I was not going to do anything but clinical practice. I was going to be a 40-hour-a-week clinician forever. I love patient care. And so I went to residency. I had some phenomenal mentors there. Susan Clinton, Diane Borello-France, Colleen Schomburg, Keelan and Seki, too many to name. But when I finished my residency, my boyfriend now, at the time, now husband, is an athletic trainer, and he got a job with TCU football. And so we moved down to Fort Worth. And so I kind of packed up, went down to Fort Worth, and got a job at a big sports medicine clinic and ended up starting their pelvic health service line. And I was then, after going from working in this heavily mentored setting with lots of other pelvic health therapists, and now the only pelvic health therapist trying to start a program, kind of not knowing what I was doing, working with a very athletic population, which was not necessarily the demographic or the only demographic that I saw in residency. So it was a big learning curve for me. Still very interested in clinical practice. The PhD was not on the radar at all, but I started seeing a lot of the same problems that I would then go to the literature in pelvic health, and there were no answers. And it was frustrating, and I didn't know how to best serve my patients. And I did what a lot of us do, is we make educated guesses or hypotheses, and we try to apply principles that we know from other areas of the body. And I tried to do the best that I could. And a lot of the times, you know, patients got better, you know, on some kind of scale to, you know, 10% better to 100% better. And sometimes they didn't get better. And then I had to figure out, okay, what are our next steps? And at this time, I guess I should kind of back up and say, I took the WCS exam after I finished residency. I passed, but I was a little bit of a perfectionist, more than I am now. And I looked at my score breakdown, and I had scored very highly in all the areas except for pregnancy. And part of that was because we didn't see a large pregnancy population in the clinics that I worked at in residency. And so I just didn't have the experience that I had in the other areas. But I thought, well, the first thing that I need to do now is beef up my knowledge in pregnancy. And it just so happened that Valerie Bobb, who's a leader in the space of pregnancy physical therapy, she was the former residency director at Baylor Scott and White. She was at Texas Women's University in Dallas, and I'm in Fort Worth. And I thought, how could I not take advantage of the fact that one of the leaders in this space does not only live close to me, but she teaches and educates in this area. So, I called her up. We actually met at CSM and we chatted. And so I decided to enroll in the post-professional women's health program at TWU, which is a 12-credit program where you go through 4 classes. That is the didactic content for their residency program. And when you do this, they tell you that if you decide at any point that you want to pursue a PhD, you could use those 12 credits as your elective credit. Jenny at the time said, not doing a PhD, I'm a clinician. I just want to be a better clinician. So I did the program, went back to my clinical practice, started getting some better outcomes in the pregnancy postpartum space, still having a lot of questions. There's no answers in the literature. And then my husband gets a job with Oklahoma State football. So the day after we got married, he's like, by the way, we're going to move to Oklahoma. And for everybody that knows me, I'm from St. Louis, Missouri. I went to University of Michigan, so lived in Ann Arbor for undergrad, went back to St. Louis for PT school, went to Pittsburgh for residency. So I'm a mid-city kind of girl. So even though Stillwater is one of the biggest cities in Oklahoma, it is still exceptionally rural compared to all the other places that I've lived. So I wasn't super jazzed about the idea of moving to Oklahoma, but I love my husband and he's amazing at what he does. So we packed up and we moved to Oklahoma. So in Oklahoma, I know this is getting to be a very long-winded story, but we're almost getting to the end.
This is great. This is why we got you here.
So I ended up working at a clinic in Stillwater, one of the only PT clinics in Stillwater, affiliated with the hospital. One of the only clinics that took all kinds of insurance, Medicare, Medicaid. A wonderful experience in that we saw very medically complex patients across the lifespan. And so I think I got exposed to some things that I never would have had the opportunity to have been exposed to had I been somewhere else. But again, I came in, they had another therapist at the time who was interested in pelvic health, but didn't have a lot of training. And so I ended up starting a pelvic health program for them and trained her. And now I would argue that she's a better pelvic health therapist than me. She's phenomenal. And not that I think I'm amazing, but she just really blossomed and it should get a lot of credit. But again, going through the process of starting a program, which I never thought I would do once, much less twice. And then I had kind of, not a medical emergency, but I kind of started to develop some abdominal pain. I was like, oh, maybe I'm just constipated. I don't know. But it was getting progressively worse. Then I started to develop a fever, like, something's not right. And I felt sick enough that I stayed home from work that day. And then I was like, oh, something's not right. And I was like, I'm going to go to the doctor. So I went to the doctor, and it was somebody who was a referral source for me. So she knew what I did. And she's just like, oh, I need you to pee in a cup because you probably have a urinary tract infection. And I was like, well, I'm more than happy to pee in this cup for you, but I don't have any of the signs or symptoms of a urinary tract infection. And I'm pretty sure I might have appendicitis because I have pain at McBurney's point. It's rebound tenderness, was horrible, super nauseous. And again, I had a fever. I was just like, I'll pee in your cup, but can you also examine me? So she's like, yeah. So she examines me, and then she's like, oh, I think there might be something wrong with your appendix. I'm going to send you over to the hospital for some imaging. Cool, thanks. Go to the hospital, get an ultrasound, and they're like, we can't really see your appendix. And I was like, what do you mean you can't see it? And they're like, well, sometimes we just can't see it. In certain body types, it's just a little bit harder to see. So we don't really know. So then they ended up doing a CT with contrast. And they're like, just so you know, you can't have this done for another 24 hours. The contrast is really hard on your kidneys. Okay, fine. They get the results back and they still can't see anything, good, bad, or otherwise. Like, well, your blood work is like borderline, and we're not really sure. So like, you're probably okay. Just go home, and if your fever gets worse, come back to the hospital. Okay, I know my body, and I think our patients know their bodies. And when you know something's wrong, when your patients tell you something is wrong, you should listen to them. So I went home feeling progressively worse. My fever is getting higher. I had never been to the emergency room in my life. And my husband came home from work that night, and I said, I think I need you to take me to the emergency room. Something is not right here. So he's like, are you sure? I'm like, yes, I'm sure. Please take me to the emergency room. So he took me to the emergency room, had an awful experience in the emergency room with just providers kind of telling me how I was feeling, doing interventions without informed consent. So somebody gave me Zofran without asking me if I can take Zofran. I'm allergic to Zofran. So, just all these things that as a pelvic health provider, women's health provider, working with patient populations that are historically marginalized in healthcare, I was experiencing that as a healthcare provider, seeking healthcare in the system that I worked for, which was like, I was frustrated by it, but I could only imagine how our patients must feel when they don't have the knowledge or background in healthcare that we do, and they don't work for the system. So long and short, they finally get somebody to come in, examine me, and they're like, well, we're not really sure, but we'll just go ahead and take your appendix out. Okay. I wake up from the surgery. Well, nothing was wrong with your appendix, but we took it out anyways. We made one of the incisions a little bit too big. So you're at high risk for herniation. So you need to be careful. And by the way, your uterus looks like you might have cancer. So you need to go see your OBGYN immediately. Like, okay.
Wow.
So, the saga continues. I have to go to Oklahoma City, which is an hour and 20 minutes away. My husband has to take off work. I go there 2 days post-op after this laparoscopic surgery, have to go through a bunch of testing to find out that what had actually happened was that a large ovarian cyst, which I had a history of, had ruptured. And what they perceived to be as cancer was just kind of the amberous fluid that is typically present after a cyst ruptures. They're like, nothing is wrong with you. You don't have cancer. Sorry, they told you that. Yeah, I'm sorry, they told me that too.
Yeah.
So go home, and I start to feel really nauseous. This is like post-op day 2 or 3, and I am projectile vomiting, and I feel something rip in my abdomen. And I was like, this is not good. And I was like, something is not right. And so I try to call the doctor to get in, and they're just like, well, do you have a fever? And I said, no. And they're like, well, we're not going to see you. I'm like, well, you told me that I'm at a high risk for herniation.
Right.
I vomited. I felt a popping sensation in the area of that incision. I would really like to be seen, and they wouldn't see me. So at this point, I didn't really know what to do. So I called my dad, and I was like, Dad, what should I do? He's like, I'll get you an appointment with somebody at WashU, like, come home and we'll get you seen. So I ended up getting seen. And what had happened was I had torn my internal oblique off of my ribs, and I'd torn some of the costochondral cartilage. Didn't herniate, which was good. But it's just a wild story to say that, I've heard from so many patients about how they have been treated poorly by the healthcare system. And I know that we need to do better and we need more answers. And then I got poorly treated by the healthcare system. And that just really kind of ignited for me that we need to do better. So while I'm recovering from this episode, I was like, you know what? I think I need to go into research. Like, I want to make a difference for the patients that I see, but I want to make a difference for more people than I could possibly see in my clinic alone. And so that's when I ended up applying for the PhD program. I got in, went through my PhD, decided that I loved research and I wanted to do more research, and didn't feel like from a hybrid program that I had the amount and the extent of research training that I needed to move into the position that I hope to move into one day. So I sought out a postdoc, and I'm now in my postdoc position and loving life. I still treat patients. I treat patients on Saturdays, so not completely out of patient care. But yeah, so that's my story.
Ooh, I need a refresher break after that. That is quite the story. Thank you so much for sharing it and for being vulnerable and just kind of giving everybody your real life experience. And like you said, there's so much to take from that. I think one of the first things that you mentioned that we see a lot in these episodes is that people's journey and path is not always straight and narrow. And the road to academia and beyond is not always, something that you expect, right? Sometimes it can just happen. I think it is kind of funny though that you had the self-fulfilling prophecy of lacrosse player into now Jenny LaCrosse. That's pretty amazing in itself. But yeah, I think the big takeaway for me there is that you went through all this and you kind of already had in the back of your mind that like the research wasn't out there. I'm starting to get the feel that I need to do more and be more in that area because it's underrepresented right now. It just doesn't exist. So I'm just going to do the damn thing myself. And that's what I love about it because again, I find a lot of that in some of the stuff that I'm into and the research that I'm into, and when it just doesn't exist and there is that gap in the knowledge, so to speak, like you get sick of hearing that, like, well, we don't really know, or it doesn't really exist, or the research isn't out there. So finally, you just have to say, fine, I'll do it. I'll do it my damn self. Like you have to, because that nobody else is going to do it. So you've got to be that person that kind of steps up and takes the call, so to speak. And so thank you for doing that, not only for yourself, but really for your patients, and like you said, the final thing that it really struck me was impact, like you could treat a couple of patients a week and make them better. And that would be great. And you'll affect those 8 people or 10 people and maybe some of their family members. And that's great. But when you're actually looking for a way to make bigger impact, like for me, it went from treating the 8 to 10 patients a day to now educating the 30 some odd students every semester that are going to go ahead and then treat 8 to 10 patients a day, to then teaching the teachers how to teach better for those students to go out and treat 8 to 10 patients a day, right? So like the impact factor just keeps growing, and there's a million different ways to do that and approach that. And you kind of found a way through research. So, whew, super cool story. Thank you again for sharing that. Jenny and I actually presented on a panel together at CSM about terminal degrees and different ways to get there and different types of terminal degrees. And I think the next question then begs, like, why? Like people say all the time, like, oh, I'm burnt out of the clinical. I think I just want to go teach. Like, okay, well, that's a possibility. It may not, solve the burnout issue, but it's a possibility. Oh, I want to go, get a PhD or pursue a terminal degree. It's like, oh, okay. Again, the big question for me is why, right? Like it all comes back to that why. So, Jenny, talk to us a little bit about the why. Like your why is pretty evident, I think, like you put it out there pretty bold and just said, this is what I need to do to make a bigger impact and help more people. What do you tell people when they ask you if they should pursue a terminal degree or, a PhD or, go into a postdoc program or something?
That's a fantastic question. And I want to walk back. I'm going to answer your question. But one of the other things that really drew me to research, especially in pelvic health. I don't know how many pelvic health physical therapy researchers there are in the United States right now, but I am not a betting woman. But if I were, I'd say there's probably less than 50, and there's probably even less than that. There are certainly other healthcare professionals, occupational therapists, nurses, nurse midwives, physicians that are doing research in this space. But in terms of physical therapists doing research in this space, we're pretty outnumbered in terms of who is doing this work, physical therapists in other countries, and then other areas of physical therapy that are being researched. And one of the things that's challenging about clinical practice in pelvic health is I don't feel like we have as many objective measures as there are in some other areas, just because what we're trying to measure is inside the body and it's a little bit harder to measure. But you can't really know if you're affecting change if you don't measure it, and if you don't know where you're starting and where you end up. Because we could certainly use patient-reported outcome measures, but we know that those are really filled with bias, especially, if your patient is trying to please you, or, there's a power dynamic there. And so sometimes in certain spaces, people will say from my clinical experience, I know this, or we don't need the evidence police to say these things. And your clinical experience is an N of 1. And that's fantastic that it helps that one person. And individualized care is so important, but we need to be able to objectively measure things. We need those measures to be valid, and we need them to be reproducible across populations. And so that was the other impetus for me wanting to get into research, was to hopefully develop some better clinical tools that we can use in pelvic health to be more objective with our assessments, so then we can better evaluate how effective our interventions are. So back to your question, what do I tell people when they ask me about getting a PhD? I first in my head usually laugh, to be completely honest. But then I ask them exactly what you said. Why do you want to get a PhD? I think there are a lot of very valid reasons, or any terminal degree for that matter. There are a lot of valid reasons that are very personal and depend on your own life circumstance. But regardless of what terminal degree you decide to pursue, if you decide to pursue it, it is a lot of hard work. And I know that you can speak to that firsthand. And so it's not something to commit to lightly. It can, depending on what route you choose, can have a financial cost associated with it. And so those are things to think about. And then I always ask people, what do you ultimately want to do with a degree? Or what's your impetus for pursuing it? And as I've gotten older, I've actually fallen away from saying, what's your 5-year plan? What's your 10-year plan? Because if you would have asked me 5 years ago what I thought I was going to be doing now, it's not what I'm doing now. And I love what I'm doing now. But I think, again, if you're thinking about a terminal academic degree, which depending on what it is, can be anywhere from, 3 to 4 to 7 to 8 years, that's a big commitment. So you really want to think about, what am I trying to do with this degree? And even though there are a lot of right answers, to speak to your experience and what you tell people, I think there are some wrong answers. And I think, the one wrong answer that stands out to me is that I'm burnt out clinically. And so now I just want to move into this other space, which at that point, I would encourage people to reflect on, what does burnout mean to you? Can you dive deeper into what circumstances are contributing to your feelings? And is there something that needs to change in your work situation, in your home situation? Or do you really, truly want to pursue something else, which if you've given that a lot of thought and the answer is yes, then go for it. But I think, like you mentioned, burnout or the hopes of making more money, which somebody told me once, like those aren't good reasons to go into academia or
Yeah,
research.
I certainly haven't found the key to more income and revenue through academia. It pays very well and it's fulfilling, but my journey was I was an English major who never in a million years wanted to teach because my dad was an English teacher and I sat in on his classes and I was like, oh, these kids are jerks. I'm not dealing with this. But I did have in the back of my mind that eventually, wow, physical therapy is pretty physical, and like if my hands go out or my knees give out or my back goes out, eventually I could fall back on teaching when I retire. Find some little community college near a beach and teach one course for fun or whatever. That was kind of my plan until I really got into the deeper dive and saw that I could leverage the EDD in a bunch of different ways, and that really has opened the door for me. And like you said, I didn't expect to be doing what I'm doing right now, but the opportunities that presented themselves because of the terminal degree have been phenomenal. They've been great, and I've had to actually say no to many opportunities. So that's great. That's wonderful. But I will say, like you said, it's hard work. I mean, the didactic work was great. I loved it. I've said this time and time again. It's phenomenal. I love learning about learning and teaching, and that's why the EDD fit me so well because I wasn't a good learner, right? I was a rote memorizer that just skirted by somehow, right? Now I get into an EDD program and I'm like, oh, that's what real learning is. Okay, I get it now, right? So now I'm like trying to catch up and craving all the things on learning and teaching and everything. But that dissertation, man, that nearly broke me. I mean, that was tough. That was a hard process. And like I said, I don't know anybody that's like, oh yeah, my dissertation was smooth and I loved it and it was a great experience. Like it feels like a form of like academic hazing, like we went through it, so now you got to go through it. Like, good luck. um yeah, it's just tough, it's really hard. So like the fact that it worked out for me is beneficial, and I love to say that I had the foresight for it to work out this way, but truthfully I was just kind of like using it as like a backup plan, and really it was more about learning more about myself and like becoming a better learner, and it started from a place of curiosity, right? Like I didn't know I had ADHD at the time. So, like, why did I struggle so much? Why couldn't I learn very well? Like, all these things. And the EDD program really helped me to figure that stuff out. And now like I said, been great. I've leveraged it a bunch of different ways, and it's been phenomenal. But the why, I think, has to be the first question. And once you figure that out, then you can determine if it's even necessary, right? Because if you just want to teach, if you're pretty good at teaching and you like that and have a knack for it and want to teach, there's a bunch of different ways to get your feet wet teaching. I mean, I'm sure you've seen a ton of them at this point.
Absolutely. And Scott, you've talked about this on some of your other podcast episodes, but having a PhD or a terminal degree doesn't mean that you're going to be a good teacher,
Yeah.
and vice versa. And so, I've had some wonderful teachers and some horrible teachers, and some of them have had terminal academic degrees and some of them haven't. And I kind of liken it to any profession. Like there's people that are better at it. There are people that could probably skill up a little bit more. But to think that you have to be a good educator, you have to have a terminal degree. Those two things are not mutually exclusive. But I will say, when I went into TWU's PhD program, it's a hybrid program, and I really feel like it is designed a little bit more heavily towards teaching you how to be an educator in a physical therapy program, or in general, more so than a researcher, with the exception that there's a lot of variability, and you can kind of create your own path. And so if research is a little bit more what you're interested in, which is what kind of once I started going through the program, I realized you can guide your path that direction. But that PhD experience, and especially some of the coursework, wasn't necessarily super research heavy. We had the fundamentals, but I felt like we did have a lot more didactic work in how to teach and learn how to be a better educator. And something I don't know that it's unique to me. I can confidently say it's not, but I'm not a researcher who has no interest in teaching. I actually love teaching too. I think I've dedicated a lot of my time recently to trying to become a better researcher. And so as a result, you can't be good at everything, right? And you only have so much time and resource to try to get better at things. And right now I'm trying to get better at being a researcher while also trying to improve some of my clinical skills as possible. So I haven't put as much effort into trying to become the best educator I can be. But I think as a researcher, we have a responsibility to disseminate our findings. And that's why you have to get grants so you can get money to do your studies. That's why you present at conferences. That's why you publish papers. But that's why I think, especially in this space, it's important for researchers to also be educators. And being an educator can mean a lot of different things. So that could be teaching in the classroom. That could be teaching patients that you're still working with. That could be teaching in more of a mass media or a community setting. But I think it's so important to remain engaged with the end user of your research, which is why I still do clinical care, because it keeps me rooted in what is the problem, what is meaningful to the patients that I want my research to help, but then staying rooted in education to say, I'm learning all these cool things. I want to make sure that the new healthcare professionals coming up have this information so that they can continue to build on it. So there's still going to be questions and there's still going to be gaps, but hopefully the gaps that I was seeing, that those gaps are filled and now they can explore new gaps.
Yeah, some really great takeaways there, right? Like one, you mentioned that like, you've had some great teachers and some terrible teachers, right? And like you can't be everything to everybody and do all the things in academia, right? Because there's three main pillars, right? You've got teaching and education, you've got research, and you've got service to the university, the community, the students, right? Those are your three big pillars in academia. You can't be great at all three of them. You just can't because there's not enough time. Maybe you could be really good at one and kind of good at another, but the third one's going to suffer, right? So like PhDs that aren't great teachers are probably really good researchers and PhD folks, whereas DPTs who have no idea about research but are really great teachers, right? You can see the ratios kind of flip and flop sometimes. Some PhDs are great at, teaching and research. That's awesome. But then maybe the service suffers a little, right? So it's kind of as you get into it, you see how it becomes harder and harder to fulfill, and you got to keep some level of a ratio down, but you do the best you can to spread it amongst your interests and what really matters, right? So for me, I think the big takeaway there is like, okay, we're picking our path, we're figuring out what we like and what we want to focus on, at least for now, and that can change over time, right? That's totally fine. But the thing that kind of kept me rooted in education that I didn't realize till a couple years into my career was, as PTs, we educate patients all day, every day. And I
Absolutely.
didn't realize that's what it was. All right. I just thought we were having conversations and I was helping them out and, showing them what I knew. But in reality, we were educating, right? So it made sense once I started to get into the EDD. It's like, oh, a good portion of our job is educating. So now it just becomes a matter of like, okay, whatever path I choose, how do I take the thing I'm doing and make it so that it's easily digestible for that end user and that audience, right? Whether it's other academicians or researchers, or whether it's the general public, whoever it may be, right? Or students even, right? It's all about communication, right? And just getting the best you can possibly be at communicating that thing, your passion, your interest, your research, whatever it may be. You've just got to be able to communicate that clearly and succinctly at the end of the day. And if you can do that, there's a strong chance you're going to be a good educator, right? But if you're not sure, dabble, right? Like do a guest lecture, like try to do some lab assist work. Like, there's a bunch of ways to try it out. PTA programs, right? That's another great way. You don't need a terminal degree for that. Like there's uh, one of our old co-hosts, Brandon Pone, he taught an undergrad anatomy class, right? He didn't need a PhD for that. Like there's a bunch of ways to get your feet wet in teaching and educating and seeing what works for you and what doesn't, because you really do have to love it. No matter what you do, you have to be passionate about it, or it's going to be a tough journey for you no matter what. you know?
Yeah, absolutely. I've heard you say this before, but I think it's worth bringing up again because it's it's important for the audience to hear, and I always remind myself of this too. Just because you know a lot of things about something, a lot is relative, a lot compared to who or compared to what. But just because I know some stuff in pelvic health and I've been immersed in it from a clinical perspective and a research perspective, does not mean that I'm automatically a good teacher of it. I can't just say I know how to do some of the things. And so now I'm not going to prepare it all. And I'm just going to walk into a room of students who come from all different experiences, kind of levels of where they're starting out at, what their expectations are, and just say, oh, well, I'm just going to tell you what I know and just brain dump on you. That doesn't make you a good educator. And
Guilty,
so,
guilty
I,
as charged.
I mean, me as well, I've done quite a bit of adjuncting, which I love. But one beautiful thing, I adjuncted South College for one of my former CIs, Dr. Caitlin Cothey, who I think is a phenomenal educator. And when I sit in on her sync sessions or I watch her teach, I've stopped listening in those situations for content. I mean, sometimes I do. I was like, I should probably remember that or like brush up on that. But it's more the style of
Art.
what is your cadence of talking? How do you respond to questions? How do you ask thoughtful questions? And I just think she's a master educator. And so I think you can be really smart and know a lot of things, but I think, you know, my suggestion for people that want to get more into teaching, and this could be true of anything, is find the people who are doing it well or at a master level, in your opinion, and watch what they do and speak with them and, you know, seek out opportunities. Because I think that's how you get exposed to kind of learn the most dangerous kind of knowledge, which is the things you don't know you don't know.
Yeah.
Because then you can at least become aware of, oh, I know that I don't know that and I need to get better at it.
Yeah. It's gosh, it's such an interesting dichotomy because teaching really is an art form. Like there's no other way to put it, you know? Um, and it took me a while. I just thought because I did it clinically for 15 plus years, I could just come in on day one and teach because I knew all the things, right? And that's just not the case, you know. It's an art form, and it took me a while to really get there. Um, but it's I find it hard to explain the intricacies and the little details because you can watch all those greats, the masters, right? And just be like, oh man, they're so good. And oh, that's such a great technique and a great tactic, you know? But then you still need your own style. You need your own flow. Like you can take tactics and techniques and things, right? But it really is a style and a flow that you have to own. You know, you have to really become the teacher that you want to be. And that's the part that really got me. That took me a while to get there, and I'm still not there, right? But
I mean,
it's a work in
it's
progress, right?
and it's the same thing as clinicians, right? I say that my treatment style is a compilation of all of the mentors who poured into me. And then I've kind of taken some other things that are the spices of Jenny and added them to what I do. And
Thousand.
always trying to learn from new people and trying to figure out, you know, from the evidence base that I'm looking at, from my research, from other researchers in the sphere that I follow, you know, how can I improve? But you make such a good point. And, you know, something that I hadn't really considered in the education space is that even just observing great teachers or being able to point out, hey, that's a really great technique doesn't necessarily translate to your own teaching style that's effective.
Yeah, I've tried things that have totally flopped, you know. But the cool part is because it's a work in progress, right? Because I have committed to truly being a lifelong learner and trying to master my craft. I may never get there, right? May never be the Michael Jordan of educating, right? But because I'm committed to trying to learn more and be better at it, and I'm trying to strive toward expertise and authority, right? That striving toward mastery will at least land me pretty good. Like I'll be pretty good by the time I'm said and done. I'll have learned a lot, I'll have gotten a lot better. But it's funny because we almost need to rename this podcast like the Dunning-Kruger effect, because I say it so much lately that it's like you think you know everything, then you get knocked back down a peg when you start getting into the weeds. You realize, oh, I really don't know hardly anything. Now that begins my journey of actually learning and doing the things I need to do to get better at this and become more, well-rounded and better adapted at performing whatever it is, clinical or education or whatever. So, it's funny, the biases that used to scare me because I didn't know them, to now I just expect that I'm going to have blind spots. And it's like trying to find them, or at least if you can't find them, have other people help you and take feedback and point them out so that you can get better.
I think you make such a good point, and you've just highlighted what the skills of a good educator are, what the skills of a good learner are, and what the good skills of a researcher and a clinician are. And one thing, I wouldn't say that it scares me, but one thing that I feel like I've noticed, so I've been a clinician for 10 years now, so I'm not young, but I'm not old, uh, in that maybe it's been around for a while, so I'd love to hear your opinion on this. But it almost seems like with the advent of social media in the healthcare space, that not only do professionals across the three pillars of education feel like they need to continually be better or be the best, whatever the best means by the metrics that your department is using, but like you have to be popular too. And like you need people to know you, and people want more people to follow them. And I think that there's something really positive about that. But the catch 22 is like sometimes, and I'll use myself as an example. I'm not a huge, I'm more of a consumer of social media for personal entertainment, not to actually put content out for, it's not a patient, I don't have patient facing accounts, or I try to share research when I can, but I start to think, could I have a bigger impact if I'm in this research space? Should I be putting more stuff out there? Like, should I try to get this information and reach more people? But research takes a lot of time, and I don't have the time to both commit to research and spend the amount of time on social media that I perceive to be necessary to kind of quote unquote become popular or have a lot of followers. Um, and so I feel like academicians, whether you're a researcher or an educator or both, or a clinician, researcher, educator, it's like there's this pull now that you have to be really good and meet all these metrics and keep climbing within your university and within the profession. But you also have to meet these metrics within the social media world. And sometimes it feels a little crushing to me. So I'm curious what your thoughts are.
Oh man, you just opened a whole new can of worms. We're going to be here a while. No, so uh, coming from a business standpoint, I feel like we as professionals should be branding ourselves from day one. Like before we're even professionals, it has to be done appropriately, but we we have to be able to get the message out to more people, and it goes back to impact, right? And having more impact. And if you're truly committed to doing the best and being the best that you possibly can, you've got to, I tell my students this, but you've got to market yourself unapologetically, right? Meaning, like, if you know you're one of only 50 people in the nation that do research on this and have the answer, it's almost selfish to like keep it to yourself, or in a journal that might get a couple publication views or whatever, or like behind a paywall or whatever. Like, if I have the key and the answer and the golden egg, it's selfish of me to keep that and not shout it from the rooftops, right? So if you're the best physical therapist in the nation in like one particular thing, but nobody knows who you are or where you're located or what you do, your skills are going to waste. And so I feel like the same is true of academicians. Like I kind of get looked at, I think, a little bit as like the black sheep in academia for bringing business into it so much. But I truly believe that like we have so much knowledge and education and skills and experience that we become experts and authorities and masters of our craft. It's our obligation. It's like if you go to, be the hero's journey, right? And you slay the dragon. You did all the work, you become a master and you slay the dragon. Your journey's not over there. You got to go back to the village and tell them all about the journey and that the dragon is slayed and they're safe. And then the next monster is going to come and you got to go attack that one. So, like, if that's the hero's journey, is just to keep striving and getting better and pushing yourself, and you're truly committed to that, I think it brings happiness and fulfillment because you've got something that you're constantly striving to get better at. And even like I said, it's that cliche phrase, right? Shoot for the moon. Even if you fail, you fall amongst the stars, right? I may not become the Michael Jordan of education, but I'm going to learn some pretty cool stuff along the way. And I'm going to get pretty darn good because I'm practicing with intention. And as long as I keep doing that, I feel better about myself. I feel like I'm fulfilled. I'm happy. I'm learning. I'm becoming a better version of myself. Now it's my job to go back and bring it back to the village and share that with as many people as possible. Because I would rather they learn my stuff and what I know to be true based on my experience than follow half of the other crap that's out there that's, misinformation or like misguided information or like, marketing stuff, right? Like, if you can live your truth and do the thing and practice the thing you're practicing and really get good at it, I almost feel like it's an obligation for us to then disseminate it and get it out there as much as possible. And like it or not, social media has become a really great tool for that. There's pros and cons, of course. And truthfully, unfortunately, for this new generation, they're going to have to navigate it very carefully because, there's some pitfalls to it as well, right? I tell my students, if you don't want it up on a billboard somewhere, don't put it on social media, probably, right? But it can be used as a tool for good. So, like, you know, that's my 2 cents. I know it's a bit rambly and a bit soapboxy, but you know, do the best you can. Don't get overwhelmed. Don't, dock yourself or knock yourself down because you're not doing enough. We're already doing so much, right? Give yourself
I,
grace and do the best you can. That's all.
I think it is nice that, there's starting to be different metrics that certain universities, well, hopefully, I think most universities are starting to look at that do kind of consider some of these things like how many followers do you have? So how many people could you potentially reach? And so some of these alternative metrics that we're still looking at traditional metrics, but then also thinking about how to reach a broader audience. So that's something that I think about. But I really like the story of slaying the dragon. That resonates for me a lot. So thank you for sharing that.
Yeah, I mean, total English major here, but it just it I really do feel like I have an obligation to like get in the trenches, do the work, and then come back and share what I learned. It's like this may not work for everybody and it may not work for you, but this is what has worked for me. Here's what I've seen, even if it is the N of one, now it's my job to take it and figure out a way to test it on more so I can grow the N and we get more data, right? Hopefully someone else will pick up the study and run with that, but um I know we've been chatting for quite some time now, but I want to be respectful of your time. I do have one final kind of question before we get into the big one. And that's just basically like, what tips, tricks, pointers, or advice would you give to somebody who's looking to maybe become a researcher?
That's a great question. I think it depends where they're starting from, but there's a few. I'll try to narrow it into 3 tips.
Sure.
So let's see if I can come up with 3 here. So one, I think really sitting with yourself and asking yourself what your why is for why you want to get into research. And, what does that look like? What kind of research do you want to do? Do you want to be a clinician researcher? Do you want to be a pure like bench scientist researcher? Kind of the why and the what of what you want to do. Then I'd say think about what kind of, if you have decided you want to get into research and you don't necessarily need to have a PhD to do research, but I'd say that's probably the most traditional terminal academic degree that people will get to move into a predominantly research field, is to think about What are your life circumstances? What are you hoping to get out of the program? So do you want to look at a hybrid program versus a more traditional brick and mortar program? And then after looking at that, I would say, what are you hoping to get out of the experience? And try to find potential PIs that you might be interested in working with, or people that, hate to say, are doing the things that you want to do, but are maybe working in this space, to reach out to see if you can make some connections, or see, if what you thought it was going to be is what it is. Does this particular PI take PhD students? Do you have to pay tuition versus is there funding? Is what they're studying going to mesh with what your interests are? So before even thinking about, what are you going to do after the PhD? What does this look like in terms of education and teaching? The three things that I would really focus on are why and what for the program, what type of program you want to do, and then who do you want to spend the next 4 to 8 years of your life with learning from?
Yeah. Yeah. All pretty big decisions there, and really need to be considered if that's the path you're going to go down, because it is a commitment. It is not to say you can't change and pivot a little bit, but once you're on the path, you really got to see it through, and it's a commitment for sure. Well, Jenny, thank you so much again for your time and expertise and your life journey and sharing that with us today. We ask all of our guests on the show this one final question, and that question is: if you could change one aspect of higher education, whether it be DPT or otherwise, what aspect would you change, and how would you change it?
My knee-jerk reaction is to talk about the financial cost of higher education, but I think we all know that's a problem.
Yeah.
So,
Number
a
one
lot of
most
people,
given answer.
yeah. So I know a lot of people talk about the importance of business and incorporating that into programs, and I agree with that. But what I would change is kind of twofold, is that I think there needs to be better pathways and potentially federally funded pathways for PT PhD programs, like they have MD PhD programs. Um, if we want to have more researchers in physical therapy, we need the researchers in these programs to get in front of students more. Because when I was in my PT program, I went to Washington University in St. Louis. They have some phenomenal researchers there. I know there were opportunities to do research as a student, but I wasn't acutely aware of what those opportunities were. Now, would I have taken advantage of them? I don't know. But I think we need to make it a little bit more apparent and a little bit more welcoming. I think if it's federally funded or there are grant mechanisms in place, it helps to offset some of that concern that there's going to be this overwhelming debt when you get finished. It cuts back on the time that you would need to complete it. And in that same vein, I think in higher education in the healthcare space, we need to do a lot more interdisciplinary training between PT, OT, nursing, physicians, pharmacology. When we go on clinicals, and it depends on what setting you're in, we're working on these interdisciplinary teams. And I know more and more programs are starting to do collaborative activities, but I think we need to do more. And, that's easy for me to say as somebody that is not an educator in a PT program right now. I know so much has to get crammed in, but I think we really are doing students a disservice by not exposing them to the value of a team-based approach in the clinical, like in the classroom and clinical setting at the same time. Because I don't think there's any program out there that's saying like, teamwork is bad, but there's something about hearing the message that it's good, but then actually getting to learn in that team-based setting where you could say like, well, what would the nurse do in this situation? What would the occupational therapist do in this situation? What's my role in this, both as the leader and as the supporter to these other healthcare providers? I think that could really have a pretty substantial impact on all of the healthcare professional students that would be involved in the experience.
Yeah, I was kind of in charge of our IPE and our interprofessional education for our program while I was, teaching full time, and you have to cram in so much stuff. Yeah, but then just take the things you're cramming in and turn them into an IPE situation where you bring in occupational therapy or you bring in speech therapy for this assignment or nursing for this, whatever, It can be done. It's a little more work, but it can be done and it should be done, right? Because again, one of the reasons this whole podcast was started was to break down the silos, to learn best practices, to figure out what all the other healthcare educators are doing and what's working and what's not, right? Because we're going to end up working together once we get out there. We're going to, in the real world, it is team-based approach, right? And I think sometimes we can lose focus of the fact that it's patient-centric, right? Like we're trying to get the best outcomes of the patient. So the team has to work together well to get that, right? It's not about us or the docs or the nurses, or it's a team approach to get the best outcome for the patient, right? We hope, right? That's the goal.
Yeah,
And
it's the word that you've kind of been saying throughout the podcast, but it's the impact that we want to have as a healthcare team for the patients and the communities that we serve.
yeah, exactly, 100%. And it's funny too that you kind of alluded to it a little bit here, but like there's not a whole lot of DPT to terminal degree bridges or programs out there. There's just not that many. And truth be told, we have a lot of great educators that are getting older and they're going to retire. And then we're going to have a bunch of voids. And then there's all these new programs coming out. So, like, they're going to need teachers with terminal degrees. So, I think we do need to find ways to figure out that terminal degree void that's staring us in the face, and with the student loan debt, that's not making it any easier. So, like you said, federally funded or some sort of, discount to do a bridge program or something. I don't know. We gotta address that too and figure it out. But I love it. I love the takeaways. So, Jenny, thank you so much again for your time and sharing your story and just being vulnerable with us and letting us know your path to where you're at now and how it can help. I know it's going to help a lot of people figure out what they want to do with life, especially if it's in the research field. Where can people find you or reach out to you if they just have follow-up questions or want to know more about what you're up to these days and what kind of research you're working on?
Sure. So I'm on Google Scholar and PubMed, so you can take a look there. I'm on Instagram. I don't post a ton, but Instagram, I'm JENN.LaCrosse. And I'm also on LinkedIn. If you want to email me, I am pretty responsive to email. So my email is jalacross@umich.edu.
Awesome. We'll put those links in the show notes so everyone can find you easily. Dr. Jenny LaCrosse, thank you so much. It's been an absolute pleasure chatting with you today.
The pleasure's been all mine. Thank you so much.